CTVS is called a dying branch in India. Students are genuinely not taking CTVS.
This branch will never die.
So, लेकिन इस ब्रांच को बहुत ज़्यादा टॉक्सिक भी कहा जा रहा है.
तो जो लोग थोड़े टॉक्सिक हो जाते हैं, लॉन्ग वर्किंग आवर्स को नहीं बेयर कर सकते, they leave this branch and go.
CTVS will have a heavy replacement with technology in the upcoming 2 to 3 years.
We are only assisting the robot to do the surgeries. The robot is not doing the surgery.
So what would be your advice to a new cardiac resident?
कि बेटा जब टाइम मिले सो जाना, जब टाइम मिले खा लेना.
You are running a big corporate hospital. Sir, is this part true? Do doctors get a target that they have to reach or otherwise they will lose their jobs?
But they make us realize that this year, maybe this quarter, the revenue generation is less. So doc, please try to increase it.
Sir, how much can a CTVS surgeon earn in India? Hey guys, welcome to the Nachiket Bhatia Show. Today we are going to talk about the branch which is considered the least important branch in all of the super specialities in surgery. Cardiothoracic Vascular Surgery, CTVS. We have all heard that CTVS branches go empty, CTVS doesn't have a scope. And to break this rumor, to break this myth, we have a very special guest with us. He is the director and head of Max Super Speciality Ghaziabad. With 28 years of experience, he specializes in coronary bypass surgery, valve repair, minimal invasive surgery, and a lot more. He has trained at Apollo Hospitals, Rajasthan universities, and has held top positions in major hospitals in Delhi, Noida, and Amritsar. Let's put our hands together and let's welcome the respected Dr. Gaurav Mahajan. Sir, it's such an honor to have such an esteemed guest on our show. You have had a great experience, 30 years of career, 30 years of experience. So before we get onto your field, your expertise, we would like to know everything about you. How did you start, sir? Where did you do your MBBS, your MD, your MCh, the whole career?
So to start with, I am from a very small town, that is Firozpur in Punjab. So I did my initial education over there. And after that, I got a seat in MBBS in Ramaya Medical College, followed by same MS also, did in the same hospital. And then I came back to Delhi. And then it took me about 2 years to enter in my MCh, which I did from SMS Medical College, Jaipur. So this was long, say about 14 years I have spent from my school days to my MCh. So this was a journey and it was great to be on your show and to share my ideas and feelings about my branch.
Suppose that, how was your career graph, sir? Where did you first join and you have, risen up to the ranks of directors, head. Now you're a pan head for almost 2 branches for Narayana Dharamshila. So how has that journey been?
When I passed my MCh, I wanted to settle in my hometown. It was my dream. But to my bad luck, there was no hospital in Firozpur which was doing cardiac surgery. So I have to settle in 2 places, either in Delhi or in Chandigarh. So I decided to settle in Delhi. And my first job was in Apollo Hospitals, Indraprastha Apollo, New Delhi. There I worked with a very, very great cardiac surgeon, spent 1 year over there, and then switched to Max Hospital, Saket. Again, I worked there for 1 year, and I realized that this branch is becoming very difficult. And the way I was working and I actually dreamt about this branch was entirely different. My working hours were very erratic. I was not getting enough chances. So I thought that there is a lot of competition in cardiac surgery. So let me switch myself to pediatric cardiac surgery, where the competition will be less, where I may get more chances, where I can make my name as an independent surgeon. तो मैंने क्या किया कि दोबारा से अपोलो ज्वाइन किया and did my pediatric cardiac surgical training for 3 years. No adult surgery in that time. Finally, when I was in pediatrics, I realized that this branch also needs a lot of dedication. And along with that, it needs a lot of teamwork also. You need to have a pediatric anesthetist and pediatric cardiologist and pediatric intensivist. then technicians, different OT, different machines, which all the hospitals cannot afford. Only the bigger corporates can run adult as well as a pediatric program. So I thought, fine, I have already worked for 3 years in pediatrics. Now let me venture into adult. So I got a job in Punjab and I went and did independent cardiac surgeries in Punjab for 1 year. So once I started as an independent surgeon, I was lucky enough to got a call from Metro Hospital, Noida, and I came back to Delhi, started a job in Metro Hospital, Noida. Then I never looked back. There I was operating say about 40 to 50 patients per month. And after that, I joined Max Vaishali, worked there for 7 years. And now recently I have joined Narayana Health for last 1.5 years. And now I've been doing both adult and pediatrics in Narayana, Gurugram and Narayana, Delhi.
Wow, sir. Such an illustrious career.
Yes, you can say, but it needed a lot of hard work, lot of dedication. And I don't know where my day and night goes on. It just starts in the morning at 6 a.m. and ends at night by 12. That 5 to 6 hours I'll get sleep, and in that also there are so many calls I'll keep on getting. Slowly I'll discuss few more things about my branch, and then you'll come to know that why this is being done in cardiac surgery.
I have a complaint. 90% of you have still not subscribed to the channel. So before moving forward, please go ahead, press the subscribe button and click the bell icon. Amazing, sir. Sir, in your own time when you were, choosing your MCH branch, I don't know what the opinion about CTVS was. So was CTVS your first choice or did you have any other choice as well?
First of all, being a doctor was my first choice. So in the internship, I just realized that surgical career is better than the physicians, because physicians had a boring life. The whole day they'll sit in the OPD, keep on writing the prescriptions, whereas the surgeon will go in the OT, operate, come back to OPD, write prescriptions. So he's doing both the work. So I was very fascinated with the surgery. So when I did my MS, in second year of MS, you have been exposed to all the super specialties for 2 months. So that was the time I made up my mind that cardiac surgery is my cup of tea. So I should join this and give my best in that. So second year MS, I was fully decided that I'll go in this branch.
कभी आपको लगा नहीं कि कोई और ब्रांच में जाना है?
No, not at all. My first and last choice was CTVS.
Sir, I think you have seen CTVS in and out. So I'll ask you the myth that is going around CTVS.
Yeah.
I don't know if it's a myth or it's a fact. Right now, CTVS is called a dying branch in India. Students are genuinely not taking CTVS. So is that part true?
See, as far as the CTVS will be there, it will never die. Okay? Maybe I am biased because I am passionate about that. जब तक हार्ट चलेगा ना, तब तक CTVS चलेगी. काफ़ी चीज़ें हैं जो कि लोग CTVS में नहीं आना चाहते. अगर हम एक पे एक उसको डिस्कस करते हैं वन बाई वन. सो नंबर वन इज it has a long working hours, and the salary what you get is not proportionate to that. After MCH, in most of the branches, once you finish, you can operate, you can start operating independently, but it is not in CTVS. MCH खत्म करने के बाद फिर से आपको 3 से 4 साल एक हाई वॉल्यूम सेंटर में एक अच्छे सर्जन के साथ काम करने बिफोर यू बिकम independent. So as I told you that I spent almost 13-14 years doing my MCH, and after that again 3 years or 4 years, so it will become almost 17 years before becoming an independent CTVS surgeon. Might as well venture in other branches. That's what nowadays people are thinking about. They are very practical. तो पैशन अपनी जगह पर है, सैलरी अपनी जगह पर है, सेटिस्फेक्शन अपनी जगह पर है. The people who have passion, who are workaholics should join CTVS. इसके बिना ये काम नहीं चलता है. Else you can venture in many other branches where you have a good family time, where you can pursue your hobbies, where you can earn more, where you can attend all your family events. Say about your children's birthday. आप कभी किसी CTVS सर्जन को पूछिएगा, वो हमेशा अपने बच्चे का बर्थडे कभी ना कभी मिस किया होगा, कभी ना कभी मैरिजेस मिस की हैं. तो इट चेंजेस योर होल पर्सपेक्टिव टुवर्ड्स लाइफ. कूट कूट कर भर दिया जाता है कि पेशेंट इज फर्स्ट, हिज लाइफ इज फर्स्ट, बिकॉज वी आर द वंस हु आर डीलिंग विद द ओनली ऑर्गन विच इज गिविंग यू लाइफ. यू कैन से इट्स अ जंक्शन बॉक्स. ये थोड़ा सा खराब हुआ ना, सारे ऑर्गन्स हिल जाते हैं. चाहे आपका ब्रेन है, चाहे आपका किडनी है, लिवर है, all the organs will be affected if your heart is affected. So for that you need a good commitment towards your branch, then only you should come. So this branch will never die. बहुत सारे लोग ये सोचते हैं कि cardiology has taken over lot of procedures. It's true to some extent, but फिर भी बाद में स्टेंटिंग के बाद सर्जरी ज़रूरत पड़ेगी ही पड़ेगी. आजकल कुछ नए प्रोसीजर्स आ गए विच वी कॉल एज ट्रांस कैथेटर परक्यूटेनियस वाल्व रिप्लेसमेंट्स. जैसे एंजियोग्राफी करते हैं वैसे ही वाल्व रिप्लेसमेंट्स हो रहे हैं. द डेटा हैज़ नॉट कम, बट येस ओवर मे बी 5 years or 10 years these valves have to be replaced by a cardiac surgeon. So this branch will never die. Heart transplant, who can do it? Only surgeon can do it. No cardiologist, nowhere it is done. तो हार्ट ट्रांसप्लांट जब तक रहेगा, लंग ट्रांसप्लांट जब तक रहेगा, रीडू ऑपरेशंस रहेंगे, वाल्व रिप्लेसमेंट्स रहेंगे, रीडू CABGs रहेंगी, बाईपासेस रहेंगे, कार्डियक सर्जरी ब्रांच विल बी अलाइव. इट विल नेवर डाई. Only one thing is there, it needs lot of commitment, it needs passion, it needs long working hours, and it needs commitment. इसी चीज़ से लोग भाग रहे हैं और इसको ज्वाइन नहीं कर रहे हैं. That is the reason why people are saying it is a dying branch. It is not a dying branch. It will definitely come up, the boom of CTVS will come up maybe after 10 years once again. I am very sure about it.
सर लेकिन इस ब्रांच को बहुत ज़्यादा टॉक्सिक भी कहा जा रहा है.
Reasons I have already mentioned. Long working hours.
So what about the resident to resident behavior?
Now the thing is, see, every resident is different. For example, every patient is different. हर resident का patience level अलग है, हर resident का commitment अलग है. तो जो लोग committed हैं, patient हैं, they can excel into this branch. जो थोड़े टॉक्सिक हो जाते हैं, लॉन्ग वर्किंग आवर्स को नहीं बेयर कर सकते, दे लीव दिस ब्रांच एंड गो. ये सारे एग्जाम्पल्स हैं जो कि नए बच्चों को इस ब्रांच में आने से डराते हैं और वो ज्वाइन नहीं करना चाहते. When I was doing my MCh, my junior has left CTVS because of the workload, because of the work pressure. So he said that I am very much happy in doing my general surgery practice. I will not join CTVS. So one seat was vacant. So these are the few reasons why people are not joining.
So sir, if we compare the working hours between maybe let's suppose gastrosurgery and CTVS, in my own opinion, I believe that it's almost similar. Even based on that, most of the seats in NEET SS counseling, especially in CTVS, are going vacant. So can you think that there might be another reason also behind this?
Working hours you can never compare between a non-surgical and a surgical branch. Another thing is, all surgeries are major surgeries and critical surgeries. They can come in any part of the day. So if you have worked in the morning for say about 8 to 10 hours, you still don't know that in next hour some emergency is coming and you're going to stand in the OT for another 7 to 8 hours. तो वर्किंग आवर्स तो CTVS के या न्यूरोसर्जरी के किसी भी ब्रांच से बहुत ज़्यादा हैं, स्पेशली मेडिकल ब्रांचेस जो हैं।
सर एक और बात थी, जैसे कि इसमें भी कहा जा रहा है कि दैट CTVS will have a heavy replacement with technology in the upcoming 2 to 3 years. Now, is that part also stands true?
या बिकॉज देखो CTVS हैज़ इवॉल्व ओवर टाइम। एक टाइम पे कन्वेंशनल सर्जरीज की जाती थी, उसके बाद इंस्ट्रूमेंट्स ऐसे डेवलप किए कि मिनिमली इन्वेसिव हो गई स्मॉल इंसिशंस में। अब टेक्नोलॉजी और एडवांस हो रहा है तो रोबोटिक सिस्टम्स आर कमिंग। Definitely this branch is going to evolve, but whatever technology is coming, it has been run by a doctor itself. अब बोलते हैं कि भाई रोबोटिक सर्जरी, इट इज़ नॉट रोबोटिक, इट इज़ रोबोटिक असिस्टेड सर्जरी। तो वी आर ओनली असिस्टिंग द रोबोट टू डू द सर्जरीज, रोबोट इज़ नॉट डूइंग द सर्जरी। और उसमें भी बहुत कम सर्जरीज ऐसी हैं जो कि करी जाती हैं CTVS में, एंड दे हैव गुड रिजल्ट्स। मैग्निफिकेशन इज़ गुड, प्रिसिशन इज़ गुड, सो द रिजल्ट्स आर गुड। बट ऐसा नहीं है कि रोबोट से पहले सर्जरीज नहीं होती थी, उससे पहले भी सर्जरीज होती थी, उससे पहले भी रिजल्ट्स अच्छे थे। आप पूरा लिटरेचर देखिए, द मॉर्टेलिटी रेट इन कार्डियक सर्जरी इज लेस देन 1 to 2%. डेथ इज नॉट एक्सेप्टेबल, डेथ इज नॉट एक्सेप्टेबल इन कार्डियक सर्जरी। चाहे पेशेंट कितना बीमार हो, वो कहते हैं डॉक्टर साहब आया तो चलकर था, आपने ट्रीटमेंट भी दिया, सर्जरी भी की, देन वाई पेशेंट इज नॉट सर्वाइव्ड। तो बहुत मुश्किल है आजकल, आपको रिजल्ट्स अच्छे देने ही देने, इट इज़ मैंडेटरी। उसके लिए आई थिंक पेशेंट सिलेक्शन शुड बी गुड, योर प्रिसिशन शुड बी गुड, योर काउंसलिंग शुड बी गुड, योर पोस्ट ऑपरेटिव मैनेजमेंट शुड बी गुड। सब चीज़ें मिलके रिजल्ट्स देती हैं। सर्जन अकेला रिजल्ट नहीं देता है। सर्जरी सिर्फ सर्जरी करना नहीं है, सर्जरी के बाद पेशेंट को संभालना भी उतना ज़रूरी है टिल द पेशेंट इज डिस्चार्ज। कब आपको कुछ आपका हार्ट का रिदम बिगड़ जाए, एंड इट टेक्स जस्ट मिनट्स फॉर द लाइफ टू जस्ट गो फ्रॉम योर हैंड्स। तो उस पर बहुत ही इंटेंस मॉनिटरिंग, कॉन्स्टेंट विजिल, वेरी इंपॉर्टेंट टू डू ऑल दीज थिंग्स. Otherwise, you can never give good results. That's why cardiac surgery is always called as a teamwork. It's a team effort. Unlike gastro, unlike endocrinology, unlike medicine, that is a one-man show. एक ही डॉक्टर जो है सब कुछ कर सकता है उसमें. यहाँ पे एक डॉक्टर कुछ नहीं कर सकता. One doctor will be on the leg to take a vein, one will be on the chest to take a mammary, another will be on the hand to take radial artery. तो 3 डॉक्टर्स तो एट अ टाइम काम कर रहे हैं. फोर्थ इज बिहाइंड द स्क्रीन एनेस्थेटिस्ट. फिफ्थ इज देयर ऑन द परफ्यूजन मशीन, दैट्स व्हाट वी कॉल एज अ हार्ट लंग मशीन. और बाकी ग्राउंड स्टाफ जो रहता है उसमें हमारे टेक्नीशियंस, पेशेंट को शिफ्ट करने वाले जो वार्ड बॉयज़, सब ओटी में उस टाइम पर रहते हैं. सो इट्स अ ह्यूज टीम ऑफ अबाउट 10 to 15 people who are actually involved in doing the cardiac surgery and giving good results.
पहले आपने एडल्ट CTVS कर रहे थे आप, फिर आपने पीडियाट्रिक CTVS में शिफ्ट किया, एंड देन यू शिफ्टेड बैक टू एडल्ट CTVS. नाउ इफ आई जस्ट आस्क, व्हाट्स द डिफरेंस, व्हाट वर द डिफरेंसेस दैट यू फाउंड बिटवीन पीडियाट्रिक CTVS एंड एडल्ट CTVS?
जब बोलते हैं ना, जब आप ज़्यादा स्टडी कर लेते हो तो आपका फील्ड नैरो होता रहता है, राइट? सो इफ़ यू हैव डन pediatrics as well as adult, it is definitely good for you. You have improved your CV, but probably you may not get the centers which will give you position to work as to operate both in pediatrics and adults. Only the good centers like Apollo, like Max, like Narayana Hrudayalaya, here you can operate both. तो हमें क्या है कि हमारा नंबर ऑफ हॉस्पिटल्स कम हो गए. अ पीडियाट्रिक सर्जन, अ प्योर पीडियाट्रिक सर्जन डजंट पुट हिज हैंड इनटू एडल्ट, whereas adult cardiac surgeon puts hand in pediatrics as well as in adults. तो जब मैंने ये करा तो मैंने यही सोचा कि हर हॉस्पिटल में पीडियाट्रिक सेटअप नहीं हो सकता, मैं तो फंस जाऊंगा बुरी तरह. हर हॉस्पिटल पीडियाट्रिक को अफोर्ड नहीं कर सकता क्योंकि वो टीम ही अलग है. ज़्यादातर हॉस्पिटल्स एडल्ट करते हैं. जब एडल्ट करते हैं तो यू हैव नंबर ऑफ हॉस्पिटल्स टू ज्वाइन. इफ यू designate yourself a pure pediatric surgeon, you will have handful of hospitals and handful of jobs. If you say you are adult as well as pediatric, many hospitals will take you because once a while, maybe a patient of 10-year-old, that also is pediatric case, easily can be done. But if you are trained, you can do even patients of 5 kgs, 6 kgs, 8 kgs like that, and which I am doing happily nowadays in Narayana Health. तो पीडियाट्रिक्स में बहुत ही ज़्यादा पेशेंस और बहुत ही ज़्यादा प्रिसिशन चाहिए. एडल्ट्स में यू कैन हैव थोड़ा सा हम इधर उधर कर सकते हैं, पीडियाट्रिक्स यू कैन नॉट हैव. तो जो पीडियाट्रिक करता है वो एडल्ट बहुत अच्छा कर सकता है, और जो एडल्ट और पीडियाट्रिक दोनों कर रहा है उसका एक अलग बेंट ऑफ माइंड है. बिकॉज सडनली a heart which is almost say is the size of your fist, next day it will become small and hardly it will become like 4 centimeters or 5 centimeters like that. तो वो आपका बेंट ऑफ माइंड जो है वो उसी तरह से चलता है कि आज छोटा हार्ट ऑपरेट करना है, आज बड़ा हार्ट ऑपरेट करना है. नॉट एवरीवन कैन डू इट.
So what would be your advice to a new cardiac resident for the day one of his residency? क्या क्या दिमाग में रख के जाना चाहिए कि अगले 3 साल ऐसे बिताने हैं मुझे?
मेरे सर ने एक एडवाइस किया था मुझे जब मैं फर्स्ट ईयर रेजिडेंट था कि बेटा जब टाइम मिले सो जाना, जब टाइम मिले खा लेना. तो आई ऑल्सो वुड एडवाइस द सेम थिंग, क्योंकि टाइम का कुछ पता नहीं है, कब इमरजेंसी आ गया, कब आपको ओटी में खड़ा होना है और कितने घंटे खड़ा होना है. तो आप खाली पेट तो खड़े नहीं हो सकते. आपके पास इतने गट्स भी नहीं है कि आप सर को बोलें कि सर मैं 5 मिनट के लिए अनवॉश हो जाऊं, अनस्क्रब हो जाऊं, वो भी नहीं है. तो जब खा लो, जब सो लो, एंड देन बी रेडी टू फेस द चैलेंज एनी टाइम. सो दैट विल बी माई एडवाइस टू फर्स्ट ईयर रेजिडेंट, एंड ही शुड कंटिन्यू विद दिस एडवाइस till his last day of MCH.
So what were your residency days like?
As I told you, I did my MCH from SMS Jaipur. So at that time, way back in 2003-04, there were only 2 seats. And at one instant of time, there were like 100 to 150 patients in the ward. तो वो 2 ही रेजिडेंट थे जो सारे पेशेंट्स को टेक केयर करते थे. So our working hours were 2.5 days, followed by night rest, and again 2.5 days, followed by the night rest. तो इतना वर्किंग आवर्स के बाद जब मैं अपने बेड पर लेटता था तो बेड शेक होते हुए लगता था कि मैं ट्रेन में जैसे बैठा हूँ, शेक होता था. एंड माई वाइफ यूज टू कम एंड गिव मी लंच ओवर देयर. And my son was that time 1.5 years old. So he also used to come to hospital to see me. उसके बाद ना wife got MD in Delhi, so she shifted with my son here. And then once in 1 month or 2 months, I used to come to Delhi to see him. My son used to ask my wife, "Who is this?" तो बोलती थी ये जयपुर वाले पापा हैं. आई यूज्ड टू गेट शॉक लाइक भाई जयपुर वाले पापा कहीं अलग तो नहीं है, दिल्ली वाले पापा अलग हैं. तो सो आई वाज लाइक जयपुर वाले पापा. आई यूज्ड टू मीट हिम एंड यूज्ड टू गो बैक एंड अगेन आफ्टर 2 months.
सर कभी उस मोमेंट में आपको रिग्रेट होता था?
मुझे एक्चुअली कार्डियक सर्जरी के बारे कभी रिग्रेट नहीं हुआ बिकॉज आई थॉट आई वॉज मेड फॉर दिस ब्रांच. आई कैन वर्क फॉर आवर्स एंड इट इज़ माई पैशन. सो रिग्रेट तो मुझे कभी भी नहीं हुआ. इफ गिवन मी अ चांस आई विल अगेन ज्वाइन कार्डियक सर्जरी. मे बी इन माई नेक्स्ट बर्थ ऑल्सो आई विल ज्वाइन कार्डियक सर्जरी. दैट मच पैशन आई हैव.
सर क्या एक्स्ट्रा मिला आपको MCH करके? बेसिकली बिटवीन दैट यू वुड हैव बिकम अ कार्डियक सर्जन थ्रू DNB एंड नाउ यू आर अ कार्डियक सर्जन थ्रू MCH. व्हाट्स द डिफरेंस?
There's a major difference in these two. The DNBs are there in a private hospitals, whereas MCH is there always in the government hospitals. तो प्राइवेट हॉस्पिटल्स में जो पेशेंट लोड है वो कॉर्नरी आर्टरी डिजीज़ का ज़्यादा है, ज़्यादा बाईपासेस होते हैं, कॉर्नरी आर्टरी सर्जरीज होती हैं. वेयर एज इन गवर्नमेंट सेटअप्स वेयर द पेशेंट्स आर ऑफ मिडल और लोअर सोशियो इकोनॉमिक स्टेटस, उनमें वैल्व डिजीज़ ज़्यादा है, रूमेटिक हार्ट डिजीज़ ज़्यादा है, वैल्व रिप्लेसमेंट की सर्जरी ज़्यादा होते हैं. तो आई गॉट बेस्ट ऑफ द लर्निंग ऑफ बाईपास in my DNB training, and I got best of my learning in valve replacements in my MCH days, क्योंकि वो गवर्नमेंट था, ये प्राइवेट था. So in that scenario, I got both the best of the surgeries I was exposed and I have learned.
That's really great, sir. And sir, when people nowadays, basically, if a person goes for a job interview, has an MCH or a DNB from let's suppose a corporate hospital, is there any bias involved, or both are considered same?
Actually, both are considered same nowadays. But if there are two residents appearing in the interview, the selection of the MCH will be done on the priority basis.
So there is a little bit imbalance.
Yeah, slightly imbalance is there. But if the MCH is not there and the two DNB residents have applied, then definitely they will keep the DNB. They won't keep the seat vacant. They'll keep the DNB as, because they also know that it will take another 2 to 3 years to slog. So the residency has to be done after MCH or after DNB for 3 years again. तो कुछ भी चलता है, हेल्प चाहिए हमें, तो हेल्प चाहिए कहीं से भी. तो चाहे वो DNB का करे, ही हैज़ बीन एक्सपोज टू कार्डियक सर्जरी, चाहे वो MCH करे, अगेन ही हैज़ बीन एक्सपोज टू कार्डियक सर्जरी. मे बी द एक्सपोजर्स, द लेवल ऑफ एक्सपोजर्स आर डिफरेंट, बट बोथ ऑफ देम आर equally exposed.
And sir, if I talk about this on an MD level, you are a director of a hospital, sir. You have run a whole hospital yourself. So while recruitment, I mean, did you find any kind of bias between an MD and a DNB?
I normally, first of all, like, there is no bias. At times, the results of DNB were very pathetic. Hardly 10% used to pass. That was the time when people used to have biased about this. But now, over a period of years, the results of DNB has drastically improved. Now the salaries are equal and there is no bias. If two people are appearing, one is MD and one is DNB in medicine, both are considered equal and people have no problems in taking any of them, even same as me.
And so, I'll tell you something, sir. So I was talking to a couple of owners of corporate hospitals, and they told me that they secretly are preferring DNBs because they know that DNB needs to be basically cleared with good clinical exposure. If you are not clinically ill, you cannot clear DNB. But MD can be cleared with your guide's help. So does that part also stand true somewhere?
I think this depends on doctor to doctor. Maybe every doctor is different. The MD doctors, they have enormous exposure, right? If you ask me, they have less working, they have less reading hours. But they have been exposed to the patients to such an extent that when the patient enters in the OPD, they will diagnose it. They are seeing maybe 200 patients in a day. Whereas a DNB resident, he might see only 10 patients in a day, but he will read the book in and out, and constant that programs are running, teaching programs are running, they can discuss. So the exposure is more in the MDs, and the teaching time DNBs get more. So it's very difficult to say that MD is not good and DNB is good, or DNB is not good, MD is good. It depends on doctor to doctor. But I think both of them are same. If you have done MD, if you have done DNB, you have to spend 2 years again in a high volume center to just polish yourself, and then you can start your independent practice.
Sir, if I just talk about, an MD surgery, MS surgery basically. So do you think in this time, doing an MCH is a compulsion, or can an MS surgery also thrive?
I am a believer of the fact that you should start your private practice as early as possible. So, second thing is, if you are residing in, say, tier 1 cities, tier 2 cities, it depends. If I would have been practicing in my hometown, I would have been satisfied my general surgery, would have never ventured into super specialty. But to make my name in bigger cosmopolitans, I have to do a super specialty and then make my name. Another variation is, if your parents are medicos, if you have a running nursing home, or if you have a running hospital, there is no need to do super specialty until and unless you have a passion about it. You can just finish it with your specialty, come join your hospital, and then take your hospital to the next level. So I think specialty is more than enough nowadays. But if you are passionate about super specialty, then you can venture into that.
Sir, अगर एक young CTVS surgeon wants to start his own private practice, what's the best time? Let's suppose immediately after his MCH. How to start that practice?
First of all, तो CTVS surgeon cannot start immediately. उसको 3-4 साल पॉलिश करना ही है अपने आप को. लगेंगे. तो he has to work in a good center where he has been exposed to all type of patients, number one. Another thing, he should improve himself in counseling. अगर उसने काउंसलिंग में अपने आप को इम्प्रूव नहीं किया तो देर आर वेरी हाई चांसेस ऑफ लिटिगेशन. तो इमीडिएटली तो नहीं हो सकता. 3-4 साल के बाद he can start his independent practice. देखिए, if you talk about CTVS, it's very difficult for a single surgeon to start his own practice, maybe a clinic or a hospital. He needs to have some investors into it, or maybe a like-minded people who can invest, because the investment is very high.
So what will be the investment?
A simple cath lab can have, say, about 1.5 to 2 CRs. A good cath lab, maybe hybrid cath lab. A surgical ICU, again, about 2 CR. And then the place. And then the building. Then the staff. So the investment is more. If you invest, maybe your second generation might earn from it. At least you won't. There's a lot of investment in that. You can never. And very important thing I will tell you today. My father got operated. Bypass surgery was done 30 years back. And I still remember I was doing my internship that time. And I paid 3.20 lakhs. 3,20,000 30 years back. और आज हम even 2.8 में 3 में भी सर्जरी कर रहे हैं. So what is this going on? In 30 years, the price of bypass surgery is same. Where are we going? Today, the price of cardiac surgery in US ranges somewhere between 1 to 1.5 lakh dollars. In UK, it is about 50,000 to 1 lakh pounds. And we are still operating in 3 lakh rupees. तो 3 lakh जब आप patient देता है तो according to that only doctor will get. Whereas if the patient is paying, maybe is paying all the patients in US, but $1 lakh,
तो क्या रीज़न लग रहा है कि आपको कि यहाँ पे प्राइस नहीं बढ़ रहा सर्जरी का?
प्राइस यहाँ पे कंपटीशन काफ़ी है.
बट स्टिल द बेसिक कॉस्टिंग मस्ट बी देयर, राइट?
हम रीयूज़ करते हैं चीज़ें.
वो कितना रीयूज कर लेंगे, उसके बाद भी 3 लाख तो कुछ भी नहीं है.
उसमें भी प्रॉफिट है हॉस्पिटल को. उसमें भी प्रॉफिट. That's why, see, cardiac surgery is a branch. That's why people say it is a dying branch, because 30 years there has been no increase in the cost of any surgery.
And it's normally between 5 to 8 hour surgery.
It's normally 5 hour surgery. From going in to out, it takes about 5 hours.
And उसके बावजूद 3 लाख में मिल रहा है.
उसके बावजूद 3 लाख है. 3 lakh, and that too in good hospitals. Many hospitals in tier 2 cities and 3 cities, they are doing for say about 1.5 lakhs, 1.8 lakhs. ये bitter reality है इसका, ये bitter truth है. इतने कम में सर्जरी हो रहा है. स्पेशली जब ये चेंज ओवर आया फ्रॉम arrested heart to a beating heart. Nowadays all the surgeries are done on a beating heart. पैसा और कम हो गया, because bypass machine is not being used. पहले हर पेशेंट पे बाईपास मशीन यूज्ड टू बी यूज्ड, तो उसमें थोड़ा सा पैसा ज़्यादा था. जैसे ही ऑफ पंप सर्जरीज आई, पैसा और कम हो गया.
Stents पे, since the government has put up a lock on the price, has that part helped?
No, not at all. The figure remained same. Before this capping, the cost of one stent with procedure was 2.5 lakhs. After the capping, the cost remains the same. Because before, the cost of stent used to be more than the cost of the procedure. And now, the cost of the stent is less and the cost of the procedure has been inflated. So at the end, patient will end up paying 2.5 lakhs for one stent. But he will definitely get benefit when he is going for a second or third stent, because second, third stent, he will add up just 30,000 plus 30, 2.5 plus 30. So if you are putting 3 stents, so 2.5 plus 30 plus 30.
Sir, how much can a CTVS surgeon earn in India 10 years, I mean, immediately after his MCH, 10 years down the line, 20 years down the line?
If you ask me, like, the starting salary of a CTVS surgeon ranges somewhere between 2 to 3 lakhs per month. Mota, it is like 10% rise every year.
Okay.
And also, it depends on how much experience you have, how many number of years post MCH you have, post DNB you have. It also depends on which city you are practicing. The more you go into the peripheries, your salary will be more. If you stay in Delhi, big metropolitan cities where competition is more, your salary will be less. Your exposure will be more, but your salary is less. Whereas in tier 2 cities, your exposure will be less, salary will be more. I think down the line, by 10 years, you will be end up paying, getting salary of say about 5 to 7 lakhs.
And 20 years down the line?
20 years down the line, if you are independent, if you are having good patient database, then 10 lakhs plus will be there. Then there is no limit about that. Minimum 10 lakhs after 20 years.
So do you think the government has done the right thing by capping the price of the stent?
I think so, because the cost of the stents, what they have been charging, was huge sum. Not everybody can afford that. I think this capping should be done in all the other surgeries also.
Too much variability was there.
Too much variability.
You call this doctor this price, you call this doctor this price.
Yeah. So that happens in India. So someone should be there to keep a check on all these things. And I think Modi ji is doing all this slowly, but yes, he's doing it.
Sir, you have run huge corporate hospitals. Sir, you have seen the government hospitals also. A couple of things that you can tell us about the way a corporate hospital has run. I'm not talking about the money, the luxury, but the way the culture is built, which is different from a government hospital.
See, corporate hospital has altogether different culture. Starting from their marketing, their track records, their revenue generation, their calculations, everything is there. And they have kept people, they have made departments. Everything has been kept at their place. At the end of 1 year, they will make you realize about your work, about your revenue generation, about your investments, about your losses, about your concessions, what you have given to the patients. Everything will be given in one sheet. Whereas these all things are not there in government setups. Government setups, you are into the surgery. That's it. Day and night you will be doing surgery. You are not bothered about cost, bringing the patients, marketing. Nothing is there. You will just focus on your skill, number of patients, and your surgeries. Your working hours are fixed in the government. Your working hours are not fixed in the corporates. Day and night you have to work. Apart from that, corporates are, because they are expanding, they are going into different cities also. So they want you to go and run OPDs in the peripheral centers in the different cities. So I myself at least visit 2 to 3 different cities in a month and run OPDs to make my name, to gather some patients. This all culture is not there in government setup. So you get good family time, you get good skills, good surgeries, and there is not much of a check on you. Because patients are so much, you cannot keep that much of check. Here you are accountable. Here every moment of yours been tracked by the corporate. So that cultures are entirely different. A people who has a mindset of working in a government setup can never work in corporate. And if you have worked in corporate from day one, you can never work in, because corporate has different problems and government setups have different problems. Both the problems are different. Politics of corporate is different and politics of government setups are different.
A question that I'm going to still ask you up. Now, I've seen a lot of general public, blaming doctors in hospitals that doctors are overdoing tests, overdoing treatment just because the hospitals have given them a target. You are running a big corporate hospital. Sir, is this part true? Do doctors get a target that they have to reach, or otherwise they will lose their jobs, and that is why they are basically overdoing the treatments and the tests?
If you talk about targets, no one uses this term with the doctors, but yes, they'll at least call us and tell us at the end of the year that the departmental revenue was this much. So it's an indirect hint. So you can say in a way that targets are given, but these targets can be met by all different variations, maybe a surgery, maybe a diagnostic modalities, maybe OPD charges. There are so many things. Everything will be counted in the revenue. So at the end, these departments are there, they will count the revenue and they will call you and they will tell you about that much of investment has been done on you and that much of fruit has been got from you. So you can say targets are being given, but no one takes the name of target and talk to us like that. But they make us realize that this year or maybe this quarter, the revenue generation is less. So doc, please try to increase it. They don't say please get some patients, try to increase it. So it is your wish, your will, how you want to.
So what can be done? Let's suppose you were the Prime Minister of India for a day. So what are the changes that you would bring in our healthcare system to, I would say, to protect both doctor and patients' rights, basically?
Very important question. And I think, first of all, the doctors should not be involved in litigation. Whatever we do with our heart. Every time, it's the death is not in our hands. But whenever the death is there, everyone will say that there is something wrong which has happened in between. So they will pull the doctor in the litigation. The training, the government should focus on the training of the doctors. If I say now the training is not, in my branch, the training is not that good. Because here we are playing with the life of the patient. So my senior, my chief should have full trust in me to do the surgery independently in front of him. If he doesn't trust me, my whole MCH will go off. He will never allow me to do even one case independently. Even one case. So that trust should be there. The teaching should be there. Nowadays, the technology has evolved so much. The simulators should be there. You cannot practice on the patient. You cannot do the surgery on the patient. You should do the surgery on the simulators, and then you should come back and do the surgery. So I would focus on the training. I would request the government that the doctors should not be treated as some sort ki bhai they should be involved in the litigation without the proper investigations. And then nowadays the anger is so much. You might have been seeing that the doctors have been beaten up.
True.
Every hospital you will find one or two cases where the doctors have been beaten up.
True.
For that, government should do something. Some security of doctors should be provided. And then the insurance should be mandatory. Nowadays, this Ayushman has come. Whosoever is 70 years and above will be getting some 5 lakh rupees of Ayushman insurance. So this insurance systems should come up so that every patient can get a good treatment. At times, when we do the surgery, we always keep billing in our mind that if we use this gadget, it will be billed to the patient. So our precision will become less. So we are scared. So we'll try to avoid that. So that thing should not be in the mind. If I am operating, I should be freely operating. I should not bother about the charges, the billing system, that how much patient has to pay. That should not be there. And in India, before discharging, the patient will again come to the doctor with a huge bill कि सर कुछ concession दिलवा दीजिए. That also is our work. Admit patient lao, admit karo, take care of the patient, do the surgery, do the post-operative workup, discharge the patient, and then help him in some concessions also. तो ये चीजें नहीं होना चाहिए. Doctors should treat them freely without having some things in the mind.
सर डॉक्टर्स की कम्युनिकेशन की प्रॉब्लम ज़रूर है. दे टेंड टू बी ओवरली रूड विद द पेशेंट्स. Many a times, like I have personally seen it happening. All right, they get too rude that the patient, just gets scared and is not able to ask any questions or anything.
आजकल बढ़ गई है ये कुछ.
बहुत बढ़ गई है सर.
हाँ, उसका रीज़न है. उसका रीज़न है this media. उसका रीज़न है this lot of content is available on ChatGPT. Lot of content is available on Google. So patients, attendants will read everything and they'll come and question us. So at times they ask totally irrelevant questions. तो irrelevance में कुछ डॉक्टर्स को गुस्सा आ जाता है, कुछ डॉक्टर्स दे आर वेरी पेशेंट सो दे डोंट से एनीथिंग. आजकल ये प्रॉब्लम बढ़ गई, पहले ऐसा नहीं था.
ठीक है सर, थैंक यू सो मच.
Thank you.
अभी सर पॉडकास्ट खत्म नहीं हुआ है. आई स्टिल हैव सम रैपिड फायर क्वेश्चंस फॉर यू. सर, बेस्ट एडवाइस यू हैव एवर रिसीव्ड?
टाइम मिले खा लो, टाइम मिले सो जो, पूरा दिन और रात का कुछ पता नहीं.
सर, वन थिंग दैट इंस्टेंटली चीयर्स यू अप?
गुड म्यूजिक.
कौन सा ऐसा फेवरेट गाना आपका?
आई लिसन टू पिंक फ्लॉयड.
अरे सर वाह, मुझे जनरल लगा था आप किशोर कुमार बोलने वाले हो.
नहीं, आई लाइक यू हैव अ थिएटर हियर.
जी.
I have my music room in my home.
Do you play something also?
I am a drummer.
क्या बात.
A wife is a singer.
Okay.
Son is a guitarist. And daughter is a keyboardist.
तो फैमिली बैंड है आपके पास?
Family band है, so we keep on jamming.
मैं आपको देख के जनरली बता सकता कि सर आप ड्रमर हो. जेन्युइनली वे. बट दैट्स अ ग्रेट थिंग सर. वन थिंग यू ऑलवेज कैरी विद यू?
My heart, my brain.
One gadget you can't live without?
Nowadays, I think mobile.
What's the first app you open every day in the morning?
WhatsApp.
WhatsApp.
Because lot of things are being done because we get lot of reports on WhatsApp. It's very difficult nowadays. Actually, the main surgeon, the main head in a single surgeon run hospitals, he is on duty 24/7. I don't know whether you know or not, there are so many groups: clinical group, investigation group, meetings group, and cultural activities group. All groups are there. So here the ECG is done, it's been posted. X-ray is done, the job is over, it's been posted. It is your wish and will what time you will see that.
Very true.
So when everything is being posted, so that means you are on call 24/7. So कुछ तो फायदे हैं WhatsApp के, कुछ ये नुकसान है डॉक्टर्स के अंदर. Then they post us reports directly from the labs. A 30-page report, a 50-page report, like that. That PDF will be posted from the lab to the doctor, not by the patient. So you have to memorize that which patient is this, which number is this. Then you'll realize, 5 days back I have advised these tests to these patients, but I advised only 4 tests. Why 40 pages are there? So these all things are not good, which is going on nowadays.
True, sir.
Phone is very essential nowadays.
So, favorite way to celebrate success?
With my family, all the time. I'm a family man, so I love to jam with my family. I love to go out for rides. And our favorite destination is Kasauli, which is hardly like 5 hours journey. Just pick up the car and go there.
So, one place in India you would recommend to everyone?
Andaman.
Did you like that place?
Very nice. Beautiful place.
So, the happiest moment of your life?
When my daughter was born. Because the astrologer told me that you will have a second son.
Thank you so much, sir. It was such a great discussion.
Thank you very much.
You gave us very genuine, honest answers, sir, and I really appreciate that.
Thank you very much.
And thank you so much, everyone, for watching today's show. I believe CTVS, we had heard so many rumors. It's a dying branch, the branch that is going vacant. But sir has told us so many honest truths about this branch that anyone who's confused about taking CTVS, he or she should absolutely watch this episode. Every bit is a gem. Thank you so much. God bless you. And don't forget to like, share, and subscribe.